It's a pleasure to have a chance to talk about this. It's an exciting title. It conjures up images that we as intensivists all like: emergency, saving lives. The word crisis, spelling out critical illness, stress-induced immunosuppression. When I first heard this advocated as the abbreviation, I wasn't quite sure it was correct for this process, but I was forced to actually go to a dictionary and realise I didn't quite understand what the word crisis means. It doesn't mean emergency per se. It comes from Greek crisis, meaning judgment, apparently, and it's a point at which there's a decisive change, a potential for decisive change, a crossroads. So a crucial or decisive situation, an unstable condition, and that's probably the ideal use in this situation. So what I'm going to talk about is what this word crisis means as an abbreviation. In order to do that, we just have to review some basic immunology, and we'll start with what happens if some of your physical barriers are breached in your initial innate immune response. Imagine you get a splinter, and you have the skin is breached. We'll get rid of that slide. Sorry, I need to just keep people on their toes. The skin is breached by something covered in bacteria that causes local tissue trauma and introduces danger signals into your bloodstream. How you respond to that is evolutionarily very well conserved, that fruit fly can do the same as we can in many ways, in that they can use complement proteins to recognize invading bacteria and sometimes lyse them. They can put proteins on the surface of the bacteria to make them more edible for phagocytic cells, and they can assemble this complex complement cascade, which you'll remember from medical school, creates little holes in the surface of invading microorganisms and blows the cells apart. And all of this is done without the host having to do much thinking about it, without having to do much adaptation. And then the phagocytes come along and clear up the mess. And in the ideal situation, every time you clean your teeth, for example, this is an effective local control that doesn't require further involvement of your immune system. You don't get sepsis most times you clean your teeth. And one of the key mediators, as we've heard, is this danger signal that sits on the surface of gram-negative bacteria, lipopolysaccharide endotoxin. And we now understand something about how the body recognises that. It's a complex process involving CD14 lipopolysaccharide binding protein and complexing together to meet another very evolutionarily conserved molecule, toll-like receptor 4. And the downstream effect of that being activated depends on which cell type you're finding that receptor on, but the organisms make neutrophils angry. They make them activated and degranulate and want to spit out toxic stuff, proteases, oxygen, radicals, etc. They hit the endothelium and makes it angry and sticky and leaky, and they also hit secondary cells, monocyte macrophages, and force them to produce pro-inflammatory secondary mediators. And so when we have a case of severe meningococcal disease, the classic view of this is that this is excessive pro-inflammation. It's profound increases in tumor necrosis factor, IL-1, etc. And we're familiar with what the patterns look like from people volunteering and having themselves injected with endotoxin and measuring in their bloodstream what happens to the levels of these cytokines. But actually, it's more complicated than that, of course. Not just do the pro-inflammatory cytokines go up, but other molecules too. IL-10 here, perhaps a little bit later, perhaps a little bit lower concentrations, but also increased. And therein lies some of the complexity. Because whenever anything happens to you, perhaps a splinter like we saw, or perhaps cleaning your teeth, you mount a local pro-inflammatory response. But you also, as in with most things in biology, mount a counterbalancing response, a local anti-inflammatory response. And often that's enough to keep the response very tightly localized, and there's no systemic spillover. But a proportion of cases, depending on the severity of the insult, your age, your genetic makeup, etc., the nature of the infecting organism, will not be contained locally. You'll spill over into your systemic circulation. And the balance of whether you get a spillover of pro-inflammation or anti-inflammation will determine the clinical picture you see subsequently. And the paper that made us all think differently about this was Westendorp's group, I think back in '96 in The Lancet. This is quite a complex paper. We'll just take you through it because the ideas behind it are crucial, I think. methodology here was to take relatives, first-degree relatives of patients who had suffered meningococcal disease, take blood from those relatives and anticoagulate it and incubate meningococci in that blood, and then look at the cytokines that that blood model produced. And if you believe the old system, you'd expect that patients who are relatives of those who died, and therefore genetically similar to them, would have more tumour necrosis factor. Actually, the opposite was true. That if you were unable to produce much TNF, or your relative was unable to produce TNF, you're more likely to be related to a non-survivor. So these are the filled circles. Whereas TNF production seems to be associated with survival in this case. What was bad was to have a predominant pro-inflammatory response, IL-10. As I say, it's a complex study. There's many interpretations can be applied. All I would want to take from it for today is that unchecked pro-inflammation is not the only mechanism for dying from severe sepsis, septic shock. So we can consider something bad happening to you, an insult, generating a pro-inflammatory response above the line. If it is overwhelming, there are a proportion of cases, and severe purpuriform anans would be perhaps a good example, where you fall straight into multi-organ failure, via the route 1, if you like, direct route into multi-organ failure. But there are other routes of getting into multi-organ failure. If you are complex supported on an intensive care unit for a long time, you are at great risk of nosocomial infection. The barriers are true and well and truly breached in this patient, as you can imagine. And there is another side to the balance that can go wrong. If you remain on intensive care unit with those breaks in your skin, with those lines, with those tubes, when the system is bringing itself back into balance, you are at risk of secondary infection. And if that is overdone, you get severe immunosuppression. You are very well ready to get a secondary infection and multi-organ failure. And that's something we can call acquired immunoparalysis or monocyte deactivation. And so broadly, we can say TNF makes you more inflamed and IL-10 makes you less inflamed. And they have some sort of balance between them. So there's a delicate balance between the pro and the anti-inflammatory cytokines. And that influences the surface expression of a particular molecule on monocytes, HLA-DR. And it influences it in a very simple way, that anti-inflammatory reduces the level and pro-inflammatory increases the level. So we can get a sort of spot check of where we are on that inflammatory spectrum by measuring HLA-DR at any one point. And it matters. This is some work from Meredith Allen on the cardiac unit at Great Ormond Street, looking at a cohort of post-op bypass cases. And this is HLA-DR stained on the surface of monocytes. Preoperatively, plenty of it around. Postoperatively, it's disappeared and takes a day or two before it comes back up. But the important association is that if your HLA-DR level on your circulating monocytes falls below a certain threshold, it doesn't particularly matter which threshold you use, your rate of developing systemic inflammation is very much higher. And here the split above 60 or below 60 in arbitrary units, the odds ratio was 17-fold for developing systemic inflammation. So this is a true risk factor that is independent of all the other things you might think determine your probability of getting sick on intensive care unit, how old you are, the type of operation, etc. Independently associated. So this phenomenon that we can observe and seems real in our populations, we can observe by something as simple as low monocyte DR expression. We know we can induce it by exposure to anti-inflammatory cytokines. And what it means for the patient is that they're less able, when faced with a new challenge, perhaps meeting endotoxin again, for example, they're less able to produce pro-inflammatory cytokines when and where they need them. And it's, as I said, a major risk factor for late infection. So I'd like you to think of, there are two routes into pro-inflammation. There's the first one, which is just going too fast and too hard, disproportionately vigorous into pro-inflammation, and that gets you into trouble. The other one, there you go, that gets you into trouble. The other one, and I quite like this one, is just failing to respond when everyone else does so. Okay, this is a 400-meter heat in the 1980 Olympics. I saw this live on television, actually. And what I love about it is the way you just, oh, well, not to worry. 4 years training just gone. Anyway. Okay, so if we're going to talk about crisis and generating immune insufficiency, one of the axes we're talking about is the initial cytokine response, being pro or anti-inflammatory. But one of the other properties of this cytokine response is that it directs later adaptive immune responses. And I find this as terrifying as you do, and we're going to take it very slowly, and I hope it's going to be a little bit clearer. One of the axes on which adaptive immunity has to choose a path is classified as Th1, Th2. And this is the nature of the T-cell maturation that predominates. We're just going to isolate down to Th1 to look at first of all. So this is what's happened is that some processing has gone on. Antigen-presenting cells have picked a little bit of the invading microorganism, presented it on their surface to T cells, and depending on the depending on the nature of that antigen and the surrounding cytokine pattern, it will determine whether they go Th1 or Th2. I think it's useful to think of the main aim of this mechanism is to generate cytotoxicity, so effective killing of virally infected cells. That would be perhaps the typical example. And the consequence of Th1, a predominant Th1 response, are, well, first of all, it's promoted by pro-inflammatory cytokines, particularly promotes killing of virally infected cells. So we have activated CD8 cytotoxic T lymphocytes. We have activated natural killer cells. But alongside that, we have lots of macrophage and neutrophil activation ready for killing and phagocytosis. So it's a very vigorous side of the immune response. The balancing response is called Th2 and is predominantly involved in antibody production. And so we have an invading microorganism here. We're producing antibody to it, and that covers the surface. It should be obvious to you quite quickly then, but there's a problem with this. You've got a nicely opsonized bacteria, but you haven't got any effector cells to come and kill it. So the ideal response is to have both elements of Th1 and Th2 in the same way as the cytokine balance requires pro and anti. Th2 is driven by these anti-inflammatory cytokines. Perhaps its main role is developing mature B lymphocytes and antibody production. So you need both for an effective and balanced immune response that can deal with invading organism. So there you go. If we have a balanced response, we can also drag in an activated phagocyte to deal with this organism. So as with the cytokines, we need pro and anti effects here. I then need to just drag in apoptosis, and in no detail, cells can die by at least two ways, perhaps three now, but let's just focus on two. Apoptosis represents cell suicide. It's when they quietly go in the corner of the room and involute, package themselves up neatly so that they can be phagocytosed in a way that does not cause further inflammation. And actually, the mechanism by which Th1 causes cell death is predominantly apoptosis. The contrasting mechanism of cell death is necrosis. If this is suicide, then if apoptosis is suicide, then necrosis is the suicide bomber. It is where the cell swells, it causes massive inflammation and induces inflammation and phagocytosis much more widely. So this is a pro-inflammatory stimulus, and if you like, this is an anti-inflammatory stimulus. So the Th2 leads to necrosis, and Th1 to apoptosis. So the consequence of this is that both systems effectively have a negative feedback loop built into them. Lots of apoptosis allows effective packaging and phagocytosis of the killed cell. And when a monocyte or a macrophage has eaten a killed cell like this, it's so full, it's like it's sitting on the sofa, completely stuffed, unable to do anything. Okay, and it becomes effectively inert. So you balance the Th1 pro-inflammatory with an anti-inflammatory effect of post-apoptosis. And the opposite is true. When exposed to necrosis, the whole thing gets more inflamed. So this should start to ring alarm bells for us, because we have congenital conditions where apoptosis is abnormal or even sometimes absent. Hemophagocytic lymphohistiocytosis, some of you may be unfortunate enough to care for in your everyday life. We certainly are at Great Ormond Street. And these patients get stuck, effectively, in a Th1 phenotype, because they cannot cause widespread lymphocyte apoptosis, and so there's nothing to switch off this process, and they just pour through Th1 and do very badly in multi-organ failure. So there's very little inhibition. But there are iatrogenic causes which can accelerate apoptosis, and perhaps the most widespread is using steroid therapy, particularly dexamethasone. And if we have lots of apoptosis, we get massive inhibition of the pro-inflammatory response. We get a big signal to switch off, and perhaps that's another element that leads us to acquired immunosuppression. So two axes that overlap, they share cause and effect, a pro-inflammatory, pro and anti-inflammatory initial cytokine response, and a Th1 versus Th2 adaptive immune response. Obviously, this is more complicated because monocyte HLA-DR expression is part of the cause, and reduced monocyte macrophage activation is part of the consequence. So these things are in themselves in tight feedback loops. The next thing I want to touch on before we talk about treatment is the influence of stress hormones on apoptosis control. And I pretty much forgot about prolactin after medical school, but it's coming back. It's an anterior pituitary hormone. It's released during stress. It does antagonize a number of cortisol effects. And importantly, it has an effect that limits lymphocyte apoptosis. Us as intensive care doctors often look after patients with low prolactin levels, though we often don't recognize it, I suspect. It can be part of the general pituitary dysfunction you get when you're sick, or, as I've hinted, it can be iatrogenic. And so prolactin, if there's prolactin normally will act to limit apoptosis and therefore to limit this feedback. So low prolactin levels will cause more feedback and more immunosuppression. And Joe Carcillo's group has done a study in the German Journal of Immunology that helps link some of these observations. This is a clinical study looking at lymphocyte counts and making an association in the proportion of patients in which autopsy data were available between excessive lymphocyte apoptosis and low lymphocyte counts. And indeed, a degree of link between lymphocyte apoptosis and monocyte deactivation, low DRs we've talked about. The clinical observation they made was that low lymphocyte counts, especially if they are prolonged, greatly increase the risk of nosocomial infection and multi-organ failure death. And there is softer data, admittedly, because of the numbers, but still links between low prolactin levels, steroid use, and to some extent dopamine use on causing both of these observations. So the whole thing starts to link together, though it, of course, is not yet a complete story. And just to show how prevalent a problem this might be for us, prolactin secretion is directed from the hypothalamus. The dopamine 2 receptor is influenced by this. If you have dopamine coming along and signaling, it reduces the hypothalamic signal and you get less prolactin around, even in as low doses of 0.1 mic per kilo per minute. That seems a bit surprising. There are some clinical data that would fit with these observations. If you look at the Cochrane database, there's just a hint that if you use norepinephrine rather than dopamine for septic shock, there is a relative risk advantage. Now, I'm not pretending to make any interpretation of this. There are so many other things that could be going on with the relative cause of choice of vasoactive agent. But how about this then? Haloperidol is a blocker of the DA2 receptor. So it will maintain prolactin function. And if you look again at the Pittsburgh group, this time the adult side, they did a large retrospective analysis of nearly 1,000 adult critical care patients and could show an all-cause mortality benefit of highly significant. And they're now running a prospective randomized trial into the use of haloperidol as a sedative agent. So it's just possible that this could be real. And interestingly, there's another agent that perhaps we're more familiar with, is metoclopramide, that has a similar effect that would maintain prolactin secretion. And there are some animal model data that suggests it allows you to resist shock and nosocomial infection better. So we have two states then that we've kind of covered. We have a sort of immune incompetent state, if you like, that has a number of features. It has a low DR and it has low tumour necrosis factor production in response to a secondary insult. We have widespread lymphocyte apoptosis and perhaps even low white cell counts, and we have monocyte deactivation. And at the other end, we have high DR, high TNF, lots of activated lymphocytes, lots of activated monocytes, and delayed apoptosis. And this, then, is what we're going to be calling crisis, and this, perhaps, in its most extreme form, is hemophagocytic lymphohistiocytosis. So that's all the background, and we have a few minutes just to touch on what we might do for treatment. What might we do for treatment is as little intensive care as possible. There's a suggestion, I won't go into the data for time, that even ventilating normal lungs pushes us towards a crisis phenotype. We don't have time to discuss. What else could we do? We could reduce the risk in other ways. We could get as much of the plastic out of this patient as possible, get them out of intensive care, and push them from this state to this state as quickly as possible. So their time exposed to risk is as little as possible. Yes, as we just heard, there's some data about using a cytokine, GM-CSF. One of the effects with the GM-CSF was having to push you through the Th1 phenotype. But on its own, that may not be effective because you've got to be able to break the feedback loop as well. That if you're not having apoptosis inhibition, you're still going to end up feedbacking into Th2. I think we've seen some of these data that some GM-CSF certainly works for putting your HLA-DR back up and restoring TNF production, but there's little clinical change associated. There is the study that we have heard of, and again this is from the Pittsburgh group, where this is the TNF responses that are restored with GM-CSF and remain low without GM-CSF. What's interesting about this is that actually we look at the children here, the control groups, and this is the number of secondary infections these patients suffered over 3 weeks of intensive care. Those given GM-CSF had no detected secondary infections, whereas those in the control groups got the normal sort of rate we would expect to see over that time course. Zinc deficiency. We've heard a little bit about giving zinc to treat pneumonia. There is a rationale for this. The zinc deficiency promotes apoptosis, and that would be a route into generating crisis. These data we saw this morning, but simple zinc supplementations, where available, can reduce pneumonia deaths in Bangladesh. Similar observations made with selenium. In preterm infants, selenium supplementation can reduce the incidence and severity of infection in very preterm infants. Glutamine, you'll have heard about over the years in conferences like this. People always have their own view on whether glutamine is effective. If you look in the systematic reviews, there is a trend towards glutamine supplementation helping restore immune function. But there's a question about the quality of the trials. So crisis in general, pro versus anti-inflammatory cytokines contribute. The nature of the adaptive response contributes, and some sort of stress hormone manipulation of apoptosis control. We will have a better idea next time we meet in, is it 2011, the next Congress, because the collaborative Pediatric Critical Care Research Network in the US is running this trial with Joe Carcillo as the lead investigator, aiming to collect 300 patients, and it's a nice trial. It's big and dirty, so it gives itself a real chance of working, if you'll forgive me saying that, Joe. The idea is to use lots of these agents together, metoclopramide, zinc, selenium, and glutamine, and with a primary endpoint of how long it takes to get the first episode of secondary infection in these patients. So we're up, I think, to 22 patients recruited, and there's the right sort of numbers of infections going on for it to fit with the control group, still getting infection at the same rate. Inclusion criteria I won't go into. So crisis then is a combination of cytokine balance, Th1, Th2 balance, and apoptosis, lymphoid depletion, and leukopenia. Remind us that the right thing to do is perhaps wait for the results, but in the meantime, be mindful of the fact that every day our child spends on an intensive care unit, with all the breaches in the skin and infection risks that are associated with that, they are at huge risk. The best thing you can do for a child in intensive care is discharge them from intensive care as soon as they possibly can. Can you extubate them? Can you remove the central venous lines? And I wouldn't be complete if I didn't say that's one approach. The other approach would just be to go for the bug side of things and not for the host, but I'm just going to leave it there. Thank you.